Hi, my name is Siva and I'm here today to present my clinical portfolio. In this presentation, I will discuss 8 evidence-based artifacts that I collected while on placement at Transitions Health and Fitness Gym in Perth, WA. I will link these 8 artifacts to the first 7 points of ESSA's AEP scope of practice, as shown at the bottom of the slide. I will then outline the level of healthcare and my placement site. This relates to point 2.8 on the scope of practice. According to ESSA, AEPs must be able to screen, assess, and apply clinical reasoning to ensure the safety and appropriateness of exercise and physical activity interventions. This includes conducting tests of physiological measures, such as waist-to-hip ratio or WHR. During my placement, I conducted waist and hip circumference measures on every new client as part of their initial assessment. I would then calculate their WHR and discuss the relevance of this with them. As a general guideline, a WHR that exceeds 0.80 for women and 0.95 for men increases cardiovascular disease or CVD risk. More specifically, a 0.01 increase in WHR is associated with a 5% increase in CVD risk. WHR is a superior predictor of CVD risk compared to waist circumference alone, as it includes a measurement of hip circumference, which is inversely associated with dyslipidemia, diabetes, and hypertension. That being said, for an obese client, WHR would be considered to be an inappropriate test, as it poorly captures the specific effects of each circumference measurement. That is, waist and hip circumferences reflect different aspects of body composition and fat distribution. AEPs must also be able to assess movement capacity in people of all ages and levels of health, well-being, or fitness. During my placement, my supervisor ran COTA WA's Living Longer, Living Stronger program. This program consists of progressive resistance training and is specifically targeted at the over 50s. As part of every new Living Longer, Living Stronger client's initial consultation, a balance assessment was conducted. The balance assessment itself consists of 6 levels, as shown in Table 1. The final level that the client successfully completes is recorded and used as a baseline indicator of the client's current level of balance ability. The tandem leg stand test, which relates to levels 2, 4, and 5, assesses lateral postural stability, a key factor in falls among older adults. Conversely, the single leg balance test, which corresponds to levels 3 and 6, is one of the oldest reported tests of balance. It's highly reliable, though it only evaluates static balance control. An AEP must also be able to develop safe, effective, individualized exercise interventions. Melaine P. is a 56-year-old and she was referred to Transitions on a diabetes care plan. In addition to type 2 diabetes, Melaine had arthritis, hypertension, and a left ankle fracture from 2 years ago. After taking relevant medical and exercise histories, Melaine's goals were discussed. Her biggest goal was to better control her type 2 diabetes and rehabilitate her left ankle post-fracture. Initial assessments such as resting blood pressure, heart rate, BMI, WHR, balance test, and 1-minute sit-to-stand test were then conducted and the results recorded. An exercise program incorporating aerobic and resistance training was then developed. Melaine was educated on the latest evidence-based research showing that a combination of aerobic and resistance training is beneficial for significant improvements in glycemic control for type 2 diabetes patients. Given that HbA1c is an important indicator of glycemic control, Yavari et al. In 2012 reported that HbA1c levels decreased by 1.33%, 0.55%, and 1.74% in the aerobic, resistance, and combined exercise training groups respectively. These findings are similar to those of Segal et al. In 2007. The following exercises were also used to rehabilitate Melaine's left ankle: ankle plantar flexion exercise with TheraBand for mobility and strengthening, and the side step-up exercise and 10-meter heel to a walk for weight bearing and balance. Melaine was then taken through one set of her exercise program as shown on the right, highlighting correct exercise technique and identifying safe exercise limits and initial starting weight for certain machine exercises. In subsequent sessions, any incorrect exercise technique was corrected. For example, Melaine was corrected when performing wall push-ups as she was keeping her elbows locked in close to her body. Reps and intensities were also progressed every 3 weeks. Initially, she was only able to complete the single leg balance exercise whilst holding the supporting wall with her whole hand. Over time, she was safely progressed to placing only one finger on that supporting wall. The provision of health education and support to enhance health and well-being is another service an AEP must be able to offer to clients. Kathy C. was an existing client at Transitions. She is 63 years old and was recently diagnosed with multiple sclerosis or MS. When I first consulted with her, she addressed some MS-related questions. I then referred her to the Multiple Sclerosis Society of WA's website. On their website, you can learn more about MS, the 4 different types, the signs and symptoms, and the treatment options. They even provide tips on how to live well with MS. Their services range from nursing, physiotherapy, counseling, and occupational therapy. And they even provide access to the latest publications in MS-related research. In addition, I answered one of Kathy C's most important questions, and that is, how is exercise going to help my MS? I told her that according to recent research, exercise may be able to delay MS-related functional decline. Moreover, a worsening of symptoms has been associated with lower levels of physical activity in MS individuals, with a p-value of 0.04. As such, engaging in exercise will be beneficial for her. With regards to the provision of health education to clients, towards the end of my placement at Transitions, I consulted with a client called Penelope S. She was 60 years old and had recently been diagnosed with osteoporosis of the hips and osteopenia of the lumbar spine. As Penelope's GP had not explained the role of exercise in the management of osteoporosis and osteopenia, I gave her a fact sheet about osteoporosis, which was developed by Exercises Medicine Australia. These fact sheets are phenomenally useful in educating clients on the role of exercise in the treatment of chronic conditions such as osteoporosis, from the benefits of exercise to the most appropriate exercise for osteoporosis. According to both articles by Kelly and Court, 2013, exercise benefits femoral, neck, and lumbar spine bone mineral density in premenopausal women and men. Moreover, Howe et al. In 2011 showed that individuals who exercise had on average 0.85% less bone loss at the spine than those who did not exercise. Furthermore, individuals who engaged in combinations of exercise types had on average 3.2% less bone loss than those who did not exercise. And in terms of fractures, 7 women out of 100 who exercised had a fracture, compared to 11 women out of 100 who did not exercise. During my placement, I provided exercise intervention programs and education for clients at risk of developing a chronic condition or injury. Violet S., a 55-year-old lady, was referred by her GP as she was pre-diabetic. After taking relevant medical and exercise histories, Violet's goals were discussed. Her biggest goal was to lose weight and lower her risk for type 2 diabetes. Initial assessments were then conducted and the results recorded. The client was educated on the latest evidence-based research showing that structured interventions combining aerobic and resistance training lower type 2 diabetes risk by up to 58% in high-risk populations. Lee et al. In 2008 also showed that even modest changes in exercise can reduce type 2 diabetes risk by 43% and delay diabetes onset an average of 3 to 6 years. These findings are supported by Gian et al. In 2007, who found that just 2.5 hours a week of brisk walking can significantly reduce risk for type 2 diabetes. Violet was then taken through one set of a program as shown on the right-hand side of the slide. In subsequent sessions, incorrect exercise technique was corrected and coaching provided. Violet had difficulty getting balance whilst doing the clock lunge, probably due to her tendency to rush through exercises, so she was asked to slow down the exercise, and sure enough, her balance improved. Minor modification of reps and intensities were also made. In previous sessions, Violet used to complete 3 sets of 10 reps of the tricep pushdown at 18 kilos. However, after 3 weeks, she was able to safely complete this exercise with 23 kilos. The provision of clinical exercise prescription for those with existing chronic and complex medical conditions and injuries is also part of an AEP's practice. David P., a 49-year-old, was referred by his GP for type 2 diabetes management. David also had hypertension and was on strong medication for this. Furthermore, he had chronic lower back pain aggravated by his work as a truck driver. After taking relevant medical and exercise histories, David's goals were discussed. His biggest goal was to better control his type 2 diabetes and rehabilitate his lower back so that he could return to work. Initial assessments were then conducted and the results recorded. Similar to Malaine P., an exercise program incorporating aerobic and resistance training was developed to address his type 2 diabetes. This same combination was also used to tackle David's hypertension. With regards to this, habitual aerobic exercise has been shown to reduce blood pressure by 7/6 millimeters of mercury in hypertensive patients, whilst resistance training has been shown to decrease blood pressure by 3/3 millimeters of mercury. Specific stretching and yoga poses were also included in David's exercise program to alleviate his lower back pain. For example, stretching the hamstring muscles in the legs up the wall exercise and reclining twist pose help expand the motion in the pelvis, thereby decreasing stress across the lower back. Moreover, yoga poses strengthen the lower back muscles so that in the future, hopefully David's work will not aggravate his lower back pain. The following instructions were also given to David prior to exercise commencement. Firstly, with regards to his lower back pain, any mild discomfort experienced at the start was normal. This should disappear when the exercise is finished and over time not arise at all. However, if pain is more than mild and persists after a particular exercise, this exercise must be stopped. Secondly, given that David's antihypertensive medications cause severe dizziness, in all future sessions he would be closely supervised, particularly during those floor exercises, and his blood pressure would be monitored pre and post each session. Furthermore, David was told that his medication may reduce maximal aerobic power and exercise heart rate. Thus, ratings of perceived exertion would be used rather than target heart rates to gauge exercise intensity. If his systolic blood pressure rose above 250 millimeters of mercury and/or his diastolic blood pressure above 115 millimeters of mercury during exercise, the session would be terminated. David was then taken through one set of his exercise program as shown on the right. Reps and intensities were progressed every 2 weeks. Initially, David used to complete 3 sets at 12 reps of the chest press at 43 kilos. This was progressed to 15 reps after 2 weeks to elicit ongoing adaptation. As AEPs, we must also be able to provide exercise-based rehabilitation and advice for patients following the acute stage of injury, surgical intervention, or during recovery to restore functional capacity and well-being. Vivian A is 74 years old and has osteoarthritis of the major joints. Around the end of May, Vivian came in and told my supervisor and me that she had fallen on her right shoulder at home 2 weeks prior. She went to her GP and thankfully no tears or fractures were detected. However, there was inflammation at the acromioclavicular or AC joint and she was in moderate pain. During her recovery, Vivian asked about what exercises she could do to alleviate the pain and restore full shoulder range of motion. After reviewing her case notes, assessing her shoulder range of motion, and consulting with my supervisor, we modified her existing program. Vivian was asked to continue with lower body exercises in her current program, but omit those upper body exercises just for the time being. Instead, shoulder range of motion exercises such as the shoulder stretch, forward and side wall crawls were incorporated. These have been shown to reduce pain as measured on a pain rating scale from 8 out of 10 to 3 out of 10 after just 3 sessions. Shoulder strengthening exercises such as internal, external rotation, and hyperextension that are commenced after the client is relatively pain-free are also imperative to restore full shoulder functional ability. Vivian was instructed to do as many reps and sets of each exercise as possible. If initially she was only able to do 1 set of the wall crawls, for example, that was perfectly fine. Pain permitting, she was asked to gradually increase reps and sets. With regards to point 2.8 of ESSA's AEP scope of practice, Transitions Health and Fitness Gym is a privately owned clinic. As such, a primary level of healthcare was provided to clients. My placement was volunteer-based, and we worked at both an individual and community health level, from working with GP-referred clients to also running Kota WA's Living Longer, Living Stronger program for the over 50s community. In conclusion, through self-reflection on my placement experience at Transitions Health and Fitness WA and the discussion of 8 different evidence-based artifacts, I have addressed all 8 points of ESSA's AEP scope of practice. As such, I feel more confident in applying what I've learned and making sound decisions in practice and do what I've wanted to do for so long, and that is to become an AEP and really help some people. To that end, here is a list of my references. Thank you for listening.